So, and I think like Mariah said, on behalf of Jen and I, we're really grateful to have this conversation, especially this time of year. Jen and I were just talking about how, July 1st, everyone talks about July 1st. That's when the new residents start. Today was actually when the second year medical students returned back for class. So it's a really timely time to talk about transitions. I'm an addiction medicine specialist as well as an OB, and we always talk about how transitions are really difficult in addiction. I think it's actually true in education. So what we're hopefully going to do, you can go to the next slide. We have a couple of objectives. I think a lot of this can be reflective, I hope, since a lot of you are very much involved in medical education. But I think a lot of it is identifying these transition points and when they are, and sometimes they're obvious, sometimes they're more subtle. We really want to help you understand and how you can really help understand what those barriers are and how we can facilitate it. But I think really helpful if you can help deploy strategies in your own world or tell us how to deploy strategies on sort of a more macro level of how we do this transition from undergraduate medical student through attending physician. There's so much to it. We're not going to do nearly enough justice to it. But I think it's just to get us thinking and be a little bit reflective at the least. And at the greatest, we'll actually have some good ideas while we can move forward. So, and like Mariah said, if you have ideas, throw them in the chat. If you want to raise your hand, it's hard for us to see that. We want to make this as much of a dialogue as the technology allows. So to start that, we'll go to the next slide. So here's a transition. It's a developmental and operational shift where a physician, future or current, moves from one stage to another, requiring adaptation to new challenges and competencies. Transitions involve changes in identity, task, supervision, assessment standards. And you can see here's a very simple one from college or undergraduate education to undergraduate medical education to GME to practice, and GME means both fellowship and residency. So a question for you guys to think about and throw it out during, either now or during the course of our talk, and we'll definitely come to that, have that as a discussion piece at the end, is what are the top challenges during transition points around the continuum that you see or you have faced yourself? And then, share them in the chat, and, we might talk about them in real time if we see them as we're talking, but we definitely want an opportunity to talk about it at the end. So next slide, I think I'll hand it over to Jed.
It's interesting when you read the definition of transition. There's a couple definitions that exist out there in the literature, but the two words that Arthur highlighted was developmental and operational. And sometimes we think about the transitions. It's like you're driving a car and you're driving smoothly on one road and then you take an exit. It's a transition, and we think you get straight on autopilot on that new road, and that's a more of a discrete transition in many ways. But this figure kind of demonstrates that developmental and operationally, it's never a smooth piece. There's always these small iterative experiences and moments that even though you're on that roadway, there's a lot of transitions that are happening even on that smooth roadway. And I think this figure demonstrates a couple things. One is that it's never a straight path. It's a circuitous journey, whether it be college to medical school, residency. Many of our VTC students, by the way, we have one of the older classes in the country by AAMC GQ data that maybe they took a year off, or there's other years that they were in work. They were fully employed and transitioned in. So then you think about their transitions into medical school, into that residency, practicing physician. In many ways, our learners that are matriculating with us here in just several weeks, they'll be in independent practice in 2031, 2032, depending upon their residency. So the other thing depicted here in the transitions is the length. It's not something that happens over 1 or 2 or 3 years. It can be upwards of 7 to 12 years when we think about all the way through our own careers, because I'm still undergoing several of my own transitions as a physician. So with that, we'll transition into the UME space. So Arthur and I, as Arthur already highlighted, we're going to break it down by UME to GME and then GME to CPD, but just providing the framework for it. So please bring your questions along and we'll have more of a dialogue at the end. There's a lot in the literature around transitions and what are the key pieces of the transition, particularly from college. And I put other there just to demonstrate that there might have been other careers or other pieces that happen into UME. And some of the key themes here are listed. I have 5 of the main categories: an academic adjustment, content itself. When you think about learners before they matriculate, they're majoring in certain disciplines or areas, and now they're coming in, and the content isn't just disciplinary. It's integrated. It's crossing several learning areas, several courses. I mean, we try really hard to integrate all five of our courses in the phase one curriculum. So that's a challenge. The pace may be different than what learners have been used to. And in many ways, it's high stakes. High stakes. It came to be physicians, and there are a number of expectations that make it challenging for a learner. There's a psychological and emotional stress. I mean, I think most of us, myself included, have gone through periods of the imposter syndrome, if you will, uncertainty for their future. Do I belong here? The first couple months, I mean, I see Leslie on the call here and Amanda and others. That first couple months, what we're coaching learners through is, in many ways, an adjustment through the psychological and emotional challenges that exist as they just moved to a new environment. Most of our learners are not from Roanoke, so the social and environmental adaptation to be in a new city, to be in a new apartment, to where's your family? The family, maybe there are no roots or social network in the geographic zone, so they're creating new networks. That leads to time management and life balance issues, all the above, to be able to do high stakes academic learning through the psychological and emotional stress. How do you balance that out? And then transition in roles and expectations. There's some labels that are placed on the difference between medical school and other higher education, that it's a transition from being learner centered. You know, if we're in college, in many ways, it's about developing our own reasoning skills and knowledge base, which is still true in medical school, but there is increasingly, in a graded manner, this transition to being patient centered. If our learners are in the longitudinal ambulatory care experience, for example, which Dr. Schmidt-Dalton and team run with our great faculty, when you're in that type of environment, oftentimes the patient comes first and learning is required in that context. But there is a transition there, and that can be different for learners as they transition into UME. But it certainly does not stop at the transition point. It's not as if our learners are going to be here in several weeks for orientation and they'll go right into our professional medicine course. It doesn't just transition straight onto that new roadway. There are all a myriad of transitions. I just wanted to highlight some of them superimposed on our curricular grid here at Virginia Tech Carilion. Our phase one curriculum runs for the first year and a half. This is the new curriculum that our current MS2s are experiencing, but our new MS1s will experience as well. And then they enter that clerkship year, a series of clerkship clusters, ends with step two study, and then it will end with phase three, the career exploration. But just some examples of what those transition are. Their first course will be the professional medicine. We'll be discussing and learning about the identities of what a physician is and what our goals are: scientist, physician, system citizen, lifelong master, adaptive learner. Our research and inquiry blocks are pretty interesting because they've existed since the beginning of the school. But in that phase one curriculum, what we have seen in our learning is that this is the time when it's not just about the books. Our learners are with mentors, they're on teams, there are deliverables, there are expectations, and that is a transition for our students to meet those expectations while learning at the same time. So it requires us to help facilitate their transition from more traditional coursework into these research blocks to do meaningful work. And then that whole phase culminates in step one study, which is pass fail. But you know, the fail rate of the step one is going up. There's a lot of anxiety around step one. So that whole phase in there, that 2 month plus period is a stress time and a transition point for our learners. And then you enter the clerkships, and there's all these micro transitions, if you will. The first time rounding on a patient on the medicine service at 6:30 a.m., I still remember waking patients up thinking, is this right? Doing an exam by myself, a breast exam, and having a nurse and asking a nurse to come in, doing that as a clerkship student. These are transitions that take time and thought. First time you scrub into the operating room is a transition. Then the step two study, which is similar to step one, but it's coming at a unique time in their journey. entering your acting internships where there is more responsibility and expectations of you, all the intentionality in that phase three as you kind of hone in on a specialty and develop mentoring networks with physicians in many ways and nurses and pharmacists, but department chairs. And that's a transition. How do you interact with clerkship directors and core faculty and chairs in a different modality as you're thinking about your transition into your specialty? And then the match is a really an eye-opening experience to go through the match. And I still remember my own transition, moving to a different place, preparing to be a physician. So there's all these lightning bolts are indicating all these transitions. It's not just a binary 0 to 1 that switches, that we need to be volitional and intentional about.
All right, so that's a perfect sort of segue to what life is in GME, and there's a lot as you go into GME. You can go to the next slide, Jed. First of all, you're a physician. You've now gone from a medical student to a physician. You are licensed, albeit with a training certificate, but still with a certain level of responsibilities. And as you look backwards from the slide, and I'm not going to really go in order, that new role is really daunting. I mean, there's a lot within GME. I'm not even talking about transition from an intern first 6 months to second 6 months to being a junior resident, being a senior resident. If you're in a procedural specialty versus a non-procedural specialty, there's so much difference in GME. The curriculum, I jokingly say GME, at least at Curly, I have 30 different fiefdoms. I have 30 different program directors doing 30 different things that they're being told by their specialties to do. And there's some unified experiences. But when you really think about this, the transition from UME to GME is incredibly predictable. 99% of our students go into residency, and we kind of act surprised, at least traditionally. I think BTC's done a great job, but nationally, it's like, why aren't people prepared? We can be much more intentional. And we'll talk more about solutions and things that are happening, locally and nationally, sort of near the end of this talk today. But there are some predictable things going on. I mean, number one, the residency application process takes up so much of the traditional fourth year. I mean, if you look at it, you map it out, there's so much opportunity for growth developmentally that kind of gets lost in the application process. And there's no simple reason for that. But I think it's also, there's so much value that applicants, medical students as are applying for residency talk about how high or low they're going to go on their rank list. And the advice I've been given for a good 10 years now, as I sort of seen so many students go through it. It's like, your top three is sort of an arbitrary designation. What programs will you be happy at overall? Which programs will you may not be as happy at? Should you even rank places you're not going to be as happy at? But a lot of it's how do you go through those transitions. So, Jed brought it up so well. I mean, they're moving to a different place. If they don't stay at the medical school they trained at, there's a lot of transitions. Workflows vary differently from place to place. I mean, I've gone through 3 different jobs in my career. And when I first got here, I remember very clearly, get me into the operating room, then I'm fine. Once I'm in an OR, I can do, but getting to the OR, the processes, the steps, you're learning a different language. People call things, some people call it a code blue, some people call it something different. You may be using a totally different electronic health record. And the EHR transition, we're seeing that right now. It's, first week of July. So our new residents who did not use Epic, they're a step behind of the students who were, somewhat fast on Epic when they were a medical student. So there's so much that they're not ready for. I think a lot of that has just been the intentionality. Yes, we have orientation. People are here for a week or 2 weeks, but that's drinking through a fire hose. I think you have a lot more time. And really, what are the essential things? And we'll talk more about developmentally things that are going to change quickly versus not quickly, and some of the foundational things that we can talk about. But I think there's, like I said, there's a lot of predictable things, and we talk more about COPA and some other things. We'll address with that. Next slide, Jed.
If I can just share a comment there,
Oh,
Arthur.
please.
In many ways, the UME breakdown, Arthur's commented on it already, but in GME, all these micro transitions. I mean, for me, my own personal experience, one of the hardest transitions I ever went through was internal medicine residency from R1 to R2. To go from pre-rounding and caring for 5 patients on an inpatient medicine service up to 7, because it's half the list, you're at 14 patients, you go to an R2 role, and now you're overseeing 2 interns, 1, 2, or 3 students, and a patient list that's up to 14 deep. And there's not a lot of programs from an R1 to an R2 transition that I experienced. It's just it just happened by osmosis. You transition into that role, but boy, was that a big shift for me emotionally, psychologically, professionally. So there's all these transitions that are happening as you unpack all these different components. Even the chief medicine or the chief resident, Arthur designed and led a chief resident boot camp, has done it now, I think, for a couple of years. But even in that, several weeks ago, the incoming chiefs are going through their own transition, which is a unique situation to be in. I don't know, Arthur, if you want to comment there.
No, no, I mean, it's totally true. I mean, I'm thinking about just my intern year. I mean, OB resident. My first 2 months run internal medicine. I took care of men. That's not what I signed up for, number one. Then I go to the ICU and I'm taking care of cardiac patients and surgical critical care patients. Very helpful. It wasn't until October I did my first OB rotation. And the response like, why are you so far behind? Well, because you set up a curriculum where I didn't do any obstetrics probably since, I don't know, August of my fourth year of residence, of fourth year medical school. So I mean, so that's part of the intentionality and part of how you design things. But I think, yeah, I mean, there's so many transitions. I mean, you'll see it, family medicine's a great one. Family medicine probably touches every single service in this hospital in their training, and how they have to be adaptable. There is a different adaptation when, in some residencies than others, but there's always something. And I think those new roles are, that transition, we talk a lot about July 1st, we have new first years, we have new second years, and new third years, and new fifth years, new seventh year residents. We're trying to figure out what their roles are because those roles become very sudden. Now you hope their skill set is gradually met to that point where they can take it over. But when you're the one responsible, and I think it's really true when you talk about the transition to being an attending, when you realize you're the one, like that's a, we prepare them for that, but it's nothing quite like, when you're the one. And I'll share a story when we go to the next slide. Ready for the next slide, Jed? Yeah, transition to practice. So, we're all experts in transition to practice, all those that are practicing physicians. Once again, I think these are predictable transitions. I think very much about, I feel like I was incredibly well trained in residency. We learned, so much being around 10,000 deliveries a year and at a big academic health center. But I remember really clearly I was a resident with one of my former resident who's now attending a few years out in practice. He's putting forceps on a patient doing actually something called a scanzoni. We don't see much of anymore. It's a rotational forcep delivery. And he puts on the forceps, goes, "Where's Dr. Ernie's? He has to check my placement," who's one of our attendings. I'm like, "You're the attending now, Alex." He's like, "Oh." He kind of looks up, says a little prayer, does a perfect delivery. He was well trained, but I think he recognized, the largest of the moment, that he is the one that's ultimately responsible now as the attending. And that assuming that truly ultimate responsibility can be pretty daunting, and you can't really think about it too much. Um, I think we recognize that. That's a known transition again. Once again, these are predictable things. We recognize that you're still learning in practice. That's why it's called practice. And I won't be ashamed to say, like, once again, I think I was well trained as a surgeon, high volume, did lots of cases, but it probably wasn't until my second or third year in practice I was doing a pretty challenging vaginal hysterectomy. But everything opened up. Like I saw the planes in a different way, and I saw the spaces. And then, like, okay, now I really feel like I understand what's going on. And that was 2 years out in practice. And that's true for everybody. I don't think I'm different than anybody else. As a proceduralist or a non-proceduralist, there's a lot to learn still. And I think the support systems are probably lacking. We spend a lot of time about orientation, from, in medical school and residency, even in fellowship. When you go into practice, no one's really orienting you. Hopefully you have good partners, you have nurses and other people that are showing to you. But I think in most places it's not super intentional. I think the other thing about transition to practice is, you know, residency, I think everyone recognizes it's probably very hard to change your residency very much. Like it's pretty much a curriculum that you go through. But I think there's a lot of hope when people go into practice. Now I can have the job I want, and now I can have the flexibility I really desire. And I think that promise of career flexibility, especially early on, is kind of hollow for many people. It's really hard when you have loans and you're trying to, if you're, trying to maintain a broad generalist practice. How do you do that and try to find that work-life balance? So I think there's that, that certain sort of disappointment, like it was going to be different, and it's not different right away. And I think it can be different. It's probably not your first job where it's different, or probably not your first years or your first job. But I think there's some of that transition, like it's supposed to be different. And you see, and I spent probably too much time looking at physician pages on Facebook saying, I'm 2, 3 years out of my residency, and this is not what I expected. Well, the question is, what did you expect and why did you expect it? But I think, we have to recognize that there's a lot going on in people's lives and how they're balancing that and what their expectations are may have varied. Um, and then I think just much like residency, I think many residency graduates are unprepared for all aspects of their practice. I'll just give one example. When I was in Asheville, we're trying to find a rural primary care workforce, and we find people that have that rural desire, but based on where they're trained, even they were trained, for a rural practice, not all rural practices are the same. So we'd have people who would like to sign up, were really excited about being in a rural practice, realize, I just don't know enough inpatient pediatrics, or I have to resuscitate newborns. And I didn't do a lot of that in residency. So, and each job is a little bit different, especially in primary care. So, we have found that when we intentionally did a rural fellowship and we bought back 10 to 20% of their time and let them learn what they needed for their specific practice, that was an incredible satisfier for that new graduate, and for the hospital system. And I think it sort of reinforced to me it's just so important to recognize that just because you learn a lot in residency doesn't mean it's going to all work out in the same way in practice, and you may need different skills, and how those get developed either intentionally or unintentionally are really, really important. Um, and then how do you fix that and why is that? So next slide, I'll just sort of give you one of my whys. I think the transition of practice has probably changed because of how physicians are employed. And this is data from Avalar Health, but you see the same thing with AMA, American Medical Association data, that the percentage of physicians that are employed by a health system has increased greatly over time. And I think that has an incredible impact. I think in the traditional model, my uncle was a traditional private practice OB. When he started to practice, his partner was highly vested in his outcomes. It was a business of two or three people, and how they looked and how they acted and how they were perceived was incredibly important. So his senior partner had so much invested in him and gave him a lot of time. They scrubbed together on cases. They were always sort of helping each other. And I think it looks a little bit different in an employed practice model, not because people aren't as invested. I think it's just the scale. It's just really hard if you're practicing for two or three people, it's a very different sort of interaction when you're in a practice of 30 people or 50 people or 100 people. And that requires a different intentionality. We can do it. It's how do you do that? Do we do a job where new attending, they get a buddy? Like who's that sort of, not sort of a mentor, but a coach? Who coaches someone, this is how things work at Carillion, or, pick your favorite health system. So I think things that were just sort of, this happened and happened innately, don't always happen innately when you change the basis and the model of care you're providing, and who hires you is a big part of that. So once again, I think there are ways of overcoming that, but I think one of the reasons that got lost is because the intentionality has to be done to scale. And that's very different than when it was just a one-on-one or a small private practice. Jen, anything you want to add before we hit the next section?
Yeah, just one comment. It doesn't 100% overlap with these comments here around the private practice model, but in medical schools, the Kaiser Permanente School of Medicine, the genesis story is very similar to what Arthur just described. The school launched, I believe in 2020 was its first matriculating class of medical students, graduating its first class of students in May of 2024, so just last year. I have to double check myself, but I think they just graduated their class just last year. But when they talk about the origin story of the School of Medicine, it came from the health system saying what the U.S. undergraduate medical education programs are sending us, if you will, the skills, the mindset doesn't totally match what we need in our healthcare system. So the transition is more choppy for us. So why don't we start a new medical school that is directly aligned with our needs? Hopefully, many will come through our medical school, enter the Kaiser Permanente system, and that transition will be better, more efficient. They used in their some of their early talks, they used the numbers of which is published, 250,000 to almost $1 million to replace a physician that is leaving practice. It costs so X amount of dollars depending upon the specialty, but it's not insignificant. So they're saying, well, our attrition rates are high. It's impacting our bottom line, but it's also impacting our outcomes. So we want to develop the skills as we see align with our health system needs. So it's just interesting, Arthur, to hear your private practice model to the story that from what I have heard from the Kaiser Permanente launch.
Yeah, no, I think that's very accurate. The Dean of Kaiser Permanente is a friend of mine, actually. He's an OBGYN, and that's what he was excited about joining them as their dean. Is like, how do we do this? And how do we really prepare the workforce in the way we see our workforce? And Kaiser has a very different approach because they're also a major healthcare employer, and they have a different lens, and that lens is actually really helpful. So 100%. So that's intentionality again, and they just did it to scale
So
because
I'm
they.
just I'm just acknowledging the comments. LB, we're coming there. I think we're going to comment on in a slide. Dr. Schlupner, Dr. Music's comment, I think will come up in one of the slides coming up as well.
Yeah, maybe the next slide.
I hope so.
Good segue.
So we're not the first to talk about the concept. I mean, this has been around in the literature, but in MedEd for quite some time, well over 10 years. And it culminated several years ago in the Coalition for Physician Accountability, the UME to GME report. So these are multiple groups coming together. This isn't just ACGME or AAMC. I think I don't have it memorized, Arthur, 10 or 14 different national bodies coming together, CME, AMA, LCME, MBME, to say, let's collaborate on some efferent arm action strategies for improving transition, particularly the UME to GME transition. And these are the 12 recommendations that they came up with. I'll let you digest some of these, and this is 4 or 5 years ago. So I think we have used this internally more than once, even in our strategic planning process. A lot of these recommendations got channeled into as fodder for our work groups. But developing a shared competency, we have the new foundational competencies for that came from the AAMC, which moved us along a little bit. But there's the harmonized milestones, for example. Many med schools are using these unified frameworks to help with that transition, moving USMLE beyond numeric scores, improving transparency, really thinking about the learner's perspective, particularly in 4 and 5 around costs. Arthur's going to comment on that in a second. And 6, expanding opportunities for advising and coaching. When you look at the literature on advising and coaching, particularly coaching the past 10 years, that has risen significantly. In addition, beyond the literature, also the programs that are actually happening in the medical schools because of the acknowledgement of not only competency-based med ed, but also the transition points to help learners through those vulnerable areas. DEI was a big piece here in 2021. Clearly, we're in a different landscape, at least from the national norms and pressures that are upon us. Reforming away rotations to make more equity, so everybody can have the opportunity to be doing away rotations, adjusting funding, and fostering collaboration. So we're highlighting this as work that's gone on nationally that in many ways have been informing and should inform many of the things that we're doing as we think about the transitions. Anything there, Arthur? Because I know you've been immersed in this.
No, I think the next slide will sort of talk about that. I think it's a great kind of setup. And I mean, this is the operationalizing of it. So I was really lucky when I was in my role at APCO as president, at the time that we had as a specialty, as OBGYN, had one of the AMA grants that we call it the Right Resident, Right Program Ready Day One. And a lot of it is taking the COPA recommendations and operationalizing it. And, the objective ones at the top, and I would say those were sort of the simpler things to do. OB/GYN has standards as far as when applications are reviewed, when interviews go out, when interviews end, how do we communicate with applicants so we take away some of the anxiety. Not, I can't say we got rid of it. I think we limited it and minimized it. We spend a lot of time with that holistic review and how we look at applications, trying to get away just from scores and trying to find a more broad-based way of evaluating applicants. We did program signaling fairly early on. We were talking about an early result acceptance program, an early match that didn't really work out, but we talk a lot about that. But I think the really cool part of the RR grant, which is the one that's still kind of being more adopted around the OB world, and definitely other specialties have come to OB asking about what we're doing, is this intern readiness, and this curriculum is how from the time you match in your program, how do you get connected with your other co-residents? How do you get connected with the program? And how do you have a really good assessment of your strengths and weaknesses? And one thing we're trying to operationalize in that, other than the coaching programs and being that intentional, is can we retake our standardized letter of evaluation, our SLO? and that's done typically in September of the fourth year, and redo it right before they come to residency as a reassessment of where are your relative strengths, where are your relative weaknesses, how can we help you, what are you going to need right away, and really make that slow, which is by design part of the application process, but that be like a living, breathing document because it's competency based, has really clear educational anchors. Is that a way to help program directors understand that everyone has weaknesses? You know, no one's intern ready because no one's intern ready. Um, but how close can you be to intern ready? And like coaching has been really helpful for that. Our resident learning communities in OB have been very important that other specialties have done this. But I think once again, it's kind of what I'm seeing in the chat is how do you be intentional and that doesn't happen accidentally. I think a lot of GME is like, well, you'll learn it because everyone learns it. Well, many people learn it, but you also can learn it quicker and better, and maybe with less anxiety if you're more intentional. Anything to add, Jed?
Yeah, the parallel to this, one example could be NYU as well. NYU, a smaller medical school, not only offers, but it's a requirement their program is 3 years. They have an additional fourth year for those who want to do other degrees or experiences. But one of the things they're proud of is their retention from UME to GME, that their numbers are remarkably high. Um, Anecdotally, the numbers nationally, I think 20%-ish, 20 to 25%. Arthur may have different references here of those that train in the UME space enter the residency programs of that same space. I think our numbers are in a similar alignment with those national numbers. NYU is pushing 40-45%. So when your numbers are higher of your UME to GME transition in the same place, you can then think about these strategic coaching models where the learner is staying in this transition from phase three, the post-clerkship curriculum, working directly with the GME programs, potentially before they match, but or at the time of match, so that when they enter that intern day one, ready day one in Arthur's model here, they've already been coached by the coaches and the faculty in the same location. Which from a learner perspective, I think personally, if I was in that type of environment, that would make sense to me. I'm knowing the faculty, I know the program I'm going into, and they're helping me transition already to hit the ground running. It's just interesting to think through models such as that. Really hard to pull off. How generalizable is that is another question.
Yeah, I think NYU is a great example. As a three-year medical school, they have to take their own applicants because it's hard to go through the match. So I think a lot of it is, I mean, I'm not sure which is the chicken, which is the egg in that standpoint, but I think it does allow them to have that more prescribed transition because A, they're already there, their relationships, but also we kind of know a lot of people are staying. So let's get them better ready day one. So it's really an interesting way to look at it, and especially like NYU Long Island, which has always been a three-year school, and they don't have a lot of GME programs, so a lot of people can't stay. So that I think that we're learning a lot from those people's experiences.
We're
Let's
down
move.
the home stretch, everybody. Great comment. Thanks, David, for putting the number in that box. So Arthur, why don't you kick us off or take us down the home stretch?
Yeah, home stretch. So, why does medical education struggle with learners transitions? I think that the chat has actually brought it up incredibly well and probably reinforced it is that we under support transitions and we're not intentional enough. I think there are a lot of ways we can be intentional and even simple things. I think it answers one of the questions about, how do you deal with the variation of experience when students come in to residence? We did this in Cincinnati when I was at the University of Cincinnati in the GME office. What we did is whenever, I asked all the program directors, what are the basic skills that residents need to be successful day one? They said putting in an IV. So this is like late 90s or early 2000s. Putting in an IV, being able to sterilely clown and glove, simple suturing, um, some basic tasks. And day three of orientation, we had them go the basic tasks and just make sure, were they proficient, were they not proficient? And if they weren't proficient, great, we could tell the program director, hey, so and so seem to be struggling on this level, something you might want to add before they start. I mean, that was just a real basic type of assessment. That was more technical skills based because it was easier to assess than some of the more, higher level interviewing skills. But I think you can definitely, if you wanted to, you could come with a list of things. And how do we know you can do it before you start? I think about, the Cincinnati Emergency Medicine Program. The first month of residency, they don't see patients. They're simming, they're doing OSCEs, they're doing all these things to get everybody on the same playing field as they can before they release them out in the patient care setting. And I think it allowed the incoming resident to feel like I feel a little bit better about everything. I got to know people, they got to know the nurses, they were doing things in team-based approaches. I think that's just like a really intentional way of getting someone ready for, a 4-year emergency medicine residency in a pretty intense inner city setting. Um, I think training occurs less in subsequent settings where physicians will practice, especially when you train people in academic health centers, they want to stay in academic health centers, and that's what they know. So it's very hard to go into rural practice or go to a suburban practice or go into the Indian Health Service. My wife went to the military. Military medicine is very different than non-military medicine as far as this the transitions that they have in the military. So once again, we try to train them the best we can, but I think we can do a better job of, especially with electives and different things, of getting people experiences where they need, um, would be great. We'll show some data in a second. People learn competencies at different times. We assume everyone's linear, and some people bring different skill sets to the table based on past experiences, based on innate skills, and everybody comes in the same. We don't expect them to come in the same. Um, but of all the different core competencies, I would hope their professionalism is pretty well established by the time they hit first year residency. Hopefully their communication skills are pretty well developed. Medical knowledge may not be. If you were a nurse, if you're a neurosurgery intern, you may have done 6 weeks of neurosurgery total. You're probably not going to know the vastness of neurosurgery. That's fine. We'll teach you that. I'll teach you how to do a C-section. That's my job, is helping people learn the theories and go into practice. So I think we have to realize that competency happens at different times, but it's definitely very clear at the beginning. Makes me think of the author, but one of the authors realized that if you look at hockey players that play for the Canadian national team, most of them are born in January, February, and March. Like, why is that? It's because when they were little kids, and the turnover date, for each level is January. Like the kids that are 6 years old are a little bit bigger. If you're born in January, you're much bigger than you're born in December. They were identified early, given lots of coaching, and they were given every advantage to succeed. And if you happen to be born in December, maybe when you're 8, 12 years old, you grew a lot, but the coaching and all the support was gone. So I think you realize, and it does always makes you realize that people go at different rates. And here's another example. This is from Tom Naska, who was the head of the ACGME when competencies and milestones came out. And and I keep this slide. I mean, he probably doesn't even know he did it. It's around the mid 2000s. But this is sort of recognizing there's a development, and you can move this development to the UME space, but not everyone's going to develop competencies at the same rate. Um, and that's okay. Um, People bring in different skill sets, different experiences. Some are just going to be innately different. Systems-based practice might be very hard to learn until you're really into it and you're really experiencing it. But then if you were a social worker or a care manager, and if you did that in your gap year, you're probably really good at it, probably better than I am. I think one more slide and we'll let Jed, here's just another example of milestones. And this is sort of a blessing and a curse. This is from the ACGME. This is national data, not Virginia Tech, not Carilion. But you can see when we look how we evaluate is a little bit limited. And this is a little suspicious, like why is everyone meeting all their milestones at the same year differently? And I don't think that's true. I think our assessment methods, especially in GME, are probably very imperfect as we're looking at different specialties trying to really do competency-based medical education. They're struggling because we don't have the assessment tools, especially when we do high risk. If we're going to start doing variable time length of residency based on achieving competency, we're not there yet. This is sort of an example of that. This is sort of the antithesis of, well, we know how they're doing. Yeah, this seems like, wow, you're a third year, you're a level 3, you're a fourth year, you're a level 4. Or maybe this is how people are developing, but I suspect probably not the case. So I think there's still an opportunity for us. How do we give feedback? How do we assess? And how do we help people along that continuum? If you don't meet with your interns a couple of times in the first 4 months, you probably aren't helping them very much. A 6-month evaluation for an intern is probably 4 months too late to really sit down with them and see how they're doing. Jed.
Yep, great comments there. LB's comment in the box, Arthur just highlighted time variable training, which I think we'll be able to get to coming up. We're almost complete. This is a study that we had done a couple years ago that comes at it from the other angle of what Arthur was just describing. This was a multi-institution study in collaboration with the ACGME, We wanted to see those schools that are doing robust health system science education versus those schools that do not articulate a very robust HSS, health system science education. How well do those graduates do in their residency program on those milestones in systems-based practice and practice-based learning and improvement? It's essentially is if you have the intervention in the UME and you're teaching all these, in theory, they should be further along on those milestones as they transition into the intern year. There's, as everybody probably knows, the holy grail really is connecting education to a patient level outcome, which is so remarkably hard to do, particularly for undergraduate medical education. But then looking at UME interventions and the impact on skill development in GME has not been done that much. So this was one of the first forays into saying how can we actually, it was a beast to actually get the data from the ACGME to make it happen. Fortunately, some higher ups were able to make this happen. When you look at ACE here in the column, they're the schools that had robust health system science education, and the control are those schools that did not. So then you're looking at the percent difference in meeting those milestones, SBP, systems-based practice, practice-based learning and improvement across these specific specialties. And you can see that for the most part, there was no identification of change or growth, A schools versus not. The 6 boxes or 5 boxes I have in yellow were those that were statistically significant. So in OB-GYN, systems-based practice 1 and 2, there was a statistically significant difference and trend towards those schools that exposed the students to health system science, but the numbers were very small. I think that was the key takeaway. One, we were able to develop a process where we assessed UME into GME, which was a win. But there weren't a lot of differences. They probably were not educationally meaningful. And it leaves a lot to unpack. Are the assessments reliable? Are they valid? Is that the right time difference? Is it assessing the right skills? Is the UME teaching and learning aligned with what those milestones are? Is there alignment? Because you could be doing a great job, but maybe the assessment would be on a different milestone that actually doesn't exist. And it raises questions how we can enhance education. So I use this as an example of this transition might be hard from an education standpoint. It's also remarkably hard, as Arthur already highlighted, from an assessment standpoint. How do you know that things we're doing in UME link really well with the GME space? Some of the transitions and ideally improvements or attenuation of the challenges in the transition really come down to identity. Arthur's commenting on professionalism, maybe medical knowledge. We can make up for that in some ways in certain areas. But the identity, this is the cruist model at the bottom of the Miller's pyramid model of knows how, shows, and does has been around for decades. But the modified amended Miller's pyramid is the cruist model where is and the identity lives at that peak. So all the knowledge and all the competencies and skills that one has, it's enveloped in this identity that comes up at the peak. And for us at Virginia Tech Carilion, it's our 3 identities that work synergistically with the patient-centered physician. But these skills that are more ubiquitous, LB's comment in the box about leadership skills and health system science, and Arthur's comment about professionalism, these more, the harmonized milestones, this is a focus for US Med Ed to be thinking about how do we ensure these transitions, no matter which specialty. It's not about the technical skills alone, it's also about these more cross-cutting skills and the identity to help our learners transition into the whatever lies ahead on the timeline for them and their growth.
Yeah, Jen, I think it speaks a lot to, it's having that expertise, and think of the GME level. I mean, GME is structured very differently. It's really focused around a model of providing care and education at the same time. But, provision of care is kind of the focus. And I think as you're looking at all these things about intentionality, I'm thinking about a job that I did not take, where they want to be a division director for a generalist division of 36 physicians, many that were very junior, and they were going to give me half a day a week to do it. Like I can't meet with them. Like if, I was just doing the math, like I was gonna spend 1 hour with each of them, that's 34 hours. I have half a day, that's gonna take me a year just to talk to them. So like they weren't investing in what they wanted. So I think it's how that how do you invest and how do you be intentional? It's a great discussion um, I think we know what we can do, but I think you have to change the systems of care a little bit because, a division director could be a really good person. Some division directors have a lot of people in them and they all have varying needs and they may not be the best people to coach. I mean, we've been, I applaud the medical school known transition, starting medical school, the PAMI program. Let's give each of the medical students a coach to help them not talk about, you know, not an advisor, not a mentor, but a coach. How do we help them go through this transition? We do it in residency in a different way, but I think we can be more intentional. I think we have a lot of opportunity into attending hood, into practice of how do you take these things. And I think we try to do some things like, the GME core curriculum, we highlight 3 topics every year: an educational topic, a health system science topic, and a leadership topic. Once again, that's educational. That's not so much the coaching, but at least it's that awareness and that's of the importance of it. You're trying to model some of that, but I think, getting to the nitty-gritty level of what's happening at the bedside, what's happening in departments, that's where systems matter. And it's adapting those systems. And I think all these ideas that people are posting of, how do you do it? These are things we have to hear so we can sort of like, how do we do that? Why can't we do that? Why do some places do it and we're still on that journey? To me, that's really important. So I appreciate these comments and hopefully as I look, this final slide is just the evolution of the white coat. And, jokingly, as I look at my white coat in the corner, it is nicely pressed, has only been used once at a white coat ceremony. I don't wear a white coat. I'm an OB. That's all I have to say. You don't want your OB wearing white coats during their course of their work. Um, but I mean, there's a meaning of the white coat, and the white coat still has incredible importance and significance. But it definitely is used very differently depending on where you are. So
I mean, yes or no, Arthur, do you still have your med school white coat?
I probably don't, but I do have my residency blue coat because we have blue coats in residency, and I have white coats from a Cincinnati job and my Asheville job. I've kept them. I think a lot of them also were used for smocks for my daughter when she was younger. It's great for painting. Old white coats are really good for kids, either for dress up or artwork.
That's all we have, everybody. Paul, please, so we see your hand up.
Oh, yeah, thank you. Yeah, I just wanted to make a couple of points. You guys touched on these, but especially for internship, fellowship, and junior attending, it really is a conglomeration of events and experiences that takes one through this journey to being a competent expert physician. But one thing is structural. So many programs, for instance, during July and August for the interns, will structure their team so a senior resident is leading that team and certain attendings who are particularly good at mentoring and guiding are on those particular teams as things go forward. And the other thing is, the notion of internship, residency, and fellowship really as an apprenticeship. You touched on this in terms of private practice, but it's true in academia as well. The old see one, do one, teach one is sort of true. And I think most of our interns and residents, although they come in at different stages, the physicians who are leading the teams and doing the procedures and instructing those particular interns and residents firsthand, along with the nurses and all the interprofessional things, are incredibly critical. So it's not just a lecture on this or a course on this or prepping in this way. It's really who your mentors are. Most of us can remember those mentors from the earlier years and throughout our lives. So what your talk has highlighted for me especially is the importance of mentorship and guidance and viewing these experiences, especially again in the GME world and junior attending world, as having an important apprenticeship aspect. Thank you.
No, thanks, Paul. I mean, there's so many good points in that. And I think, the one struggle I've had, sort of in a leadership position is when does someone need a coach versus a mentor? They're actually very different, right? And I think identifying which is the right relation to have and who's that right person to have a relationship. I would say I became a better coach after I went into addiction and I realized it's the same. I just do motivational interviewing, talk less, smile more, helps a lot. But I think that's a different skill set. So I think it's also when you identify the need, getting the right person to be that person and not flipping roles too often because it's easy to
Yeah.
sort of slip into this is how I was taught. And I had, these mentors who were, had great wisdom that never applied to me. But, they had the best of intentions.
I'll also say I'm almost talking about the hands-on, doctor or nurse who says to the intern who wants to give a patient 80 milliequivalents of potassium chloride over 10 minutes, you can't do that. And then explain why you can't do that. So much of it is just hands-on.
Yeah, great point.
Yeah, Paul, it's a reminder, at least for me, not to make assumptions. I mean, you think an M2 students here, oh, they know the routine, they're good to go. They just spent a whole year with us. But let's not make assumptions about that. Like they're going through their own transition and stretch, just like an intern coming in or an R2. Dr. Schloopner, do you want to comment? Because I know your comments in the box here related to mentorship during these transitions, similar to Dr. Skolnick's comments. Or we can go to Farrell. Farrell's got his hand up.
We'll go to Farrell for now.
I've left Charlie speechless, I think.
Okay. Um, I hope you guys can hear me. My question is sort of in regards to, one of the comments that Jed made was related to programs that have higher rates of students who are staying there for their GME program and the opportunities for longitudinal coaching there. But I was wondering if you can comment on some of the potential barriers surrounding sort of that feed forward type of feedback, and what that what that puts those individuals at risk in terms of bias, stigma, privacy. So how do those schools overcome those types of barriers? And are there other ways to implement that for students who are moving to other institutions?
Yeah, I mean, Farrell, for when we're trying to do an OB, we're going to make it, and this takes a lot of bravery, but it's going to be sort of intern led. I'm going to share where I think I need improvement. Now that takes a lot of coaching and a high level of psychological safety. So, but I mean, FERPA doesn't really apply to GME. It may or may not, depending on the instance. So there's some legal issues, but I think there's always a concern that we're going to brand somebody, oh, they're the one who struggles with not tying, or they're the one who gets nervous in front of patients. I think most times you figure that out in the end. So I'd rather address it on the front end and on the back end in most cases. But I think how that happens and the actual mechanism is a little tricky because there's a balance there, because you don't want to pigeonhole people. At the same time, you want people to, identify opportunities for growth and be brave enough to say, I need help in this area. Like, that would be, I mean, that's the ideal. How to do it is a little tricky, 100%, especially brand new intern trying to talk about these are my deepest, darkest concerns to the program director or faculty. That sounds great in theory, but I think in practice that'll be very difficult. It might be more to senior residents or other people, but you bring up some great points.
Yeah, and it also happens phase 1 to phase 2. What do we do from the pre-clerkship curriculum into the clerkship? Should we feed forward? I mean, Farrell's been in those discussions too, but I don't think there's a clear answer.
Yeah, I'm just curious. So, um, so are there, so Arthur, is that something that you're going to be implementing like right at the beginning of internship year? And if so, do they really have the experiential context to know what they don't know yet?
I mean, that's the plan. I mean, I think every transition you learn, and it's always a constant assessment, right? And if you're looking about how do you take data and improve your outcomes, you only have the data you have, right? This is what I'm worried about moving in. This is where my relative strengths lie. The learning curve, especially first year of residency, is so high, right? It's hard to know. But I think it's a start of a conversation. It's sort of an intentionality that doesn't currently exist. It'll be probably imperfect. I mean, it will be imperfect. And I don't think we've got everyone on board yet. I think we have a lot of people leadership nationally to be like, this makes sense. But the devil's in the details for sure.
Dr. Rubio, please.
I was thinking the good lecture, by the way, had very good important points, but on the people that transition from med school to residency, the good thing is that we have them here, right? So we can actually coach them and mentor them or whatever you feel is best for each person. But one of my concerns on the fellowship side is getting people ready for practice afterwards. And that's where we are not going to have as much control because we don't have anything afterwards, right? But we want to make sure they're going to succeed. And you're correct, there's about 20% private practices right now. Most everybody else is employed now. But there's also a difference between being employed in corporate for-profit medicine and being employed in an academic center. So I would say that we still have likely a majority of people that really work a more for-profit kind of private practice like model, which is quite different than the way we train people. So I think it's very important that we maybe develop some task forces or groups within sections and practices that ideally have people that have worked in private practice before or the sort of for-profit model that maybe can guide through the years, all our fellows to do that because the turnover is huge. I mean, it's still, there's about 30+% of people will change jobs within a couple of years. And definitely it is not just bad for the people hiring them, but it's bad for them because they're getting very disappointed. They're having wrong expectations of volume of patients, that affect their quality of life and work-life balance, of wrong expectations of salaries, wrong expectations of benefits, of what does it mean to work with a group of smaller people where, for instance, now everything you do impacts everybody else. And you're not just one piece of a puzzle, of a gigantic universe where it may not matter as much. And I don't think in that sense we have done a good job of setting up ways for our teams to be able to help folks get to that. And some of them come to me sometimes even worrying about billing. What am I going to do when I graduate, with my billing? Because if my billing is not up to par, my salary is going to get cut down. So I think it'd be nice to look forward to how can we implement mechanisms to address better their needs after they graduate from us.
No, great point. I mean, how structures change. When I was a resident, I would say I probably did 70% of my surgeries with private practice attendings. And the private practice attendings actually, as part of their relationship, actually covered our outpatient clinic. So there was a constant dialogue with people who are actually in real practice, whatever that meant. But I think that gets lost when you don't have those people anymore, right? So there is this, lovely intentionality of what could happen, but now as a dynamic change, how do we replace that? I think once again, I think it's how do we focus on it and how do we identify it and how each of us do it a little bit differently. Because you're right, that fellowship transition, in a subspecialty might be different than going into family medicine in a general practice or to be in general practice. So you really need that content expertise as well as the bigger picture stuff. But
Dr. Schlupner, please. I know you've been
Can you
waiting. I
hear-
know.
can
And
yeah, you get
Can you hear
to
me
carry
now?
us out of this one.
Can you hear me?
Yes, sir.
Good. There was a problem with the mic. I really want to say I think this discussion has been great, and I've been involved with mentoring both faculty and students. I was reflecting back on what happened with me, and there were no formal programs, but I generally sought out. So I think one of the things we have to rely upon and teach the students, residents, to seek a mentor, someone who provides advice. The last comment that I'll make, because I don't want to prolong this for any of us, the June 26th New England Journal had the first of a series of articles that dealt with medical education. And I read that article, and Chad DeMont and I have had some discussions back and forth by email about it. But I really think that article sets the tone for the need for UME and GME to start to talk and get together. Whether that occurs just at the individual programs level, like Korean Clinic with VTC, or wherever it is, I just think that is important because we have challenges ahead of us right now, and our profession depends upon succeeding. Enough said.
Thank you.
Thank you for leading this discussion as well.
Thank you all for leading a fabulous discussion. Clearly there are multiple points of transition beyond the obvious even that we need to think about as faculty members. If anybody, I clearly realize we're 2 minutes past. If anybody wants to stay on for a couple of minutes, has any additional questions, you can either email Arthur and Jed and or stay on for a few minutes and ask yourself. So otherwise, enjoy the rest of your day and thank you for being here.